recurrent disease, recurrent ovarian cancer, and here this is from devita. So when we talk about recurrent disease, here first devita clarifies the concept of platinum sensitivity, and they want you to know what is like platinum sensitive, partially sensitive, platinum free interval, and what is platinum resistant. So if you don't know, don't worry, I'm going to tell you. So it's important to recognize. So when you use the resist criteria of greater than 30% reduction, then you can call it partial response. And when there is like a shrinkage of 30%, you call it partial response, or if there's disappearance of the lesion, then you call it complete response. And partial response or complete response is called response. Now, patients who fail to have responded to platinum or taxane and or taxane with rising CA125 levels and worsening ascites and other stuff, you would call them platinum refractory. Okay, and those are refractory. Well, women who achieve remission after giving platinum remission, as in there will be complete response or a major partial response at least, and then within 6 months there is a recurrence of the disease. We call it platinum resistant. Women who get complete response and there is no recurrence for up to 1 year or 12 months, we call it platinum sensitive. And in patients that get a response to platinum chemotherapy but they recur between 6 and 12 months, we call it partially platinum sensitive. And with these definitions clear, we are now talking about management of recurrent disease. So when is the disease recurrent? Is it partially platinum sensitive? Is it platinum sensitive? Is it platinum resistant? Or is it platinum refractory? Now, if it is platinum refractory, then the treatment continues. So you just don't call it you don't call it recurrent, you just call it resistant disease. But everything else is recurrent. And here we know that in platinum sensitive patients, the best thing to do will be to do a platinum re-challenge and a platinum and paclitaxel carboplatin re-challenge. If at all they become resistant and start progressing on platinum, then GemCis is another treatment option. In patients who experience relapse greater than 12 months after primary platinum therapy, the landscape is we should definitely add platinum therapy again. And the ICON 4 randomized trial showed that using platinum is very beneficial. Carboplatin combined with paclitaxel gemcitabine, PLD1 was studied as to which is the best companion drug along with carboplatin. And pegylated liposomal doxorubicin was studied in the Calypso trial, which proved non-inferiority of the regimen over carbopacli. Now, interestingly, carboplatin plus PLD is associated with improved PFS and less alopecia, less neuropathy, and less allergic reactions. So you could use, instead of pacli-carbo, you could use pacli-liposomal doxorubicin too. Now, doxorubicin, our liposomal doxorubicin has a lifetime cumulative dose of 400, so be cautious in cardiotoxicity. Okay, now here what devita continues to talk about is that in recurrent disease, can we do secondary cytoreduction or not? And initially the GOG 213 showed a negative effect of doing secondary cytoreduction, which showed harm while doing secondary cytoreduction. And that was that said that it is not good to do secondary cytoreduction, which showed a hazards of 1.29. That means 29% more, surgical complications, and the OS was decreased to 50 months versus 64 months. Now there were a few extremely, I must say, ambitious and really ballsy German doctors who wanted to defy this rule, and they went on to do and they felt very optimistic of doing secondary cytoreduction, and therefore the desktop trials came in, where the desktop 1 and desktop 2 trials were done, and desktop 3 trial was done, where secondary cytoreduction was proven to be beneficial with a significant OS benefit of 45 months versus 19 months, which was great in the desktop 1 trial if they could do a complete cytoreduction only. If they were not able to do a complete cytoreduction, there was no significant benefit. And in the desktop 2 trial, again, 407 platinum sensitive patients were studied, where complete resection was achieved in 67% of the study population, and mean PFS was 14 months without and 19.6 months with secondary cytoreduction. So here in desktop 2, you get a 5-month benefit of this. In desktop 3 trial, desktop 3 again, OS was 53 with surgery versus 46 without surgery. So you get about a good OS actually, because chemo is being given. 53.7 months is a huge OS. Like from the first detection of the disease, that's about 4 years. 4 years is 48 months. So you get a huge OS of 48 months in ovarian cancer in the chemotherapy era. Now, in the case of recurrent disease, here devita continues to talk about platinum-based doublets for platinum-sensitive or recurrent disease. Okay, so ICON 4 studied paclicarbo showed that the 2-year OS was 57 versus 50. So like 57% survived with giving at a median follow-up of 42 months. So basically, like you got like 7% more survival at 2 years by using paclicarbo. And then another trial wanted to see that can we use pacli and why carboplatin, why not oxaliplatin? And so when they tried using third generation like oxaliplatin, it appeared equivalent to other platinum analogs, so it really didn't make much difference. And oxaliplatin is more toxic, and carbo is really like very well tolerated. So why simply give oxaliplatin? And then they used the GEMSIS trial on day 1, day 8, every 21 days for platinum refractory disease, and they got some response at least. So GEMSIS could be used in the refractory setting when platinum is not working. And then again back to the Calypso trial, which showed that here safety of carbo with pegylated liposomal doxa every 21 days with paclicarbo, and a median follow-up of 22 months, and the PFS for the carbo PLD arm was statistically superior to the PFS in the paclicarbo arm. So you get about 2 months PFS benefit in the recurrent setting by using liposomal doxorubicin, although there were a lot of hand-foot syndromes in the pegylated doxorubicin arm, and the improved PFS was superior. So that is about using in the recurrent setting pegylated liposomal doxorubicin. Now, non-platinum chemotherapeutic options for platinum-resistant disease. So we know it's platinum-resistant. What you're going to do? They're trying desperately other chemotherapeutic drugs because platinum is not working. So can we use topotecan? Well, topotecan did show some response, and you had 20% response with topotecan as compared to 13% with paclitaxel, although 79% patients who were given topotecan had neutropenia, but was short lasting, and so then topotecan was approved in the platinum resistant setting. But then now we got a new drug in the platinum resistant setting, that is topotecan. But after topotecan, they studied pegylated liposomal doxorubicin and pegylated liposomal doxorubicin 50 milligram per meter square every 21 days versus 1.5 milligram per meter square of topotecan every 21 days, 28 versus 21 days. And PFS and OS were similar between the two arms, but the statistically significant improvement in PFS of 28.9 weeks versus 23 weeks and OS of 108 weeks versus 71 weeks was seen in the pegylated liposomal doxorubicin arm. Therefore, pegylated liposomal doxorubicin became the drug of choice in the second line setting over here, and that's how it crawled its way through into the drug of choice in this case. Now, this EORTC trial studied that if the patient is recurred, should we panic and immediately give chemo, or can we take some time and measure the patient, observe the patient until they're symptomatic, until they have issues, and then start chemotherapy? And this trial actually surprisingly showed that even if you delay the treatment, it didn't really matter in the overall survival. Now, when we're dealing with recurrent patients, can we give anti-angiogenic therapy like bevacizumab? And then the OCEAN study showed that bevacizumab was superior to the control arm, and it showed that a better response rate of 78% was seen in bevacizumab arm versus the control group. And the Aurelia or the Avastin in recurrent ovarian cancer, platinum resistant cancer, epithelial ovarian cancer trial showed that so you need to know that in this resistant setting, the PFS is very short. So like in the control group, the PFS is 3.4 months, but adding bevacizumab in this setting double the PFS to 6.7 months. So they get about 4 months on median PFS that some people can get even 1 year, where bevacizumab keeps acting and decreases the thing. But also it's important to note that by giving weekly chemotherapy, you could delay this thing, and it acts like bev, and then immunotherapy, really nothing promising from the immunotherapy standpoint. Well, a lot of immunotherapy trials were done, but with the objective overall response rate was, you have multiple immunotherapy trials such as Javelin, Athena, and IMA kind, and all of this was predominantly really nothing promising over here in immune checkpoint inhibitors. It's really new though that immunotherapy is used in ovarian cancer, so a lot of studies are going on, and be like very premature to say anything, but a few results was like PFS of 19.4 versus 18.4, like with not significant confidence. So all negative trials basically in the immunotherapy space. And then there are some special therapies where you have the folate receptor and CAR T cells, and then you have the vaccines kind of treatments which are undergoing. Folate receptor is a promising space, but all these things are just very not commonly used, and these are subject to studies. Thank you.